Okay. All right. Let me see first. So again, firstly, this is not ideal lah. Medical students, doctors, you need to learn how to become doctors with looking at patient. That has been the way from the very beginning. Even if you look at the times of Ibn Sina, if you look at the times of other all the ancient doctors as well, they learn medicine by assessing patients. It has never been the way to learn how to become doctors by doing online teaching, remote teaching, and so on and so forth. This is not ideal. But anyway, we don't have that much option. So I think because we don't see things is going to get better anytime soon. So I think the decision for year 3 is that you all will finish all the 4 blocks first. And then we'll have the face-to-face teaching. I think somewhere in April or May, you all will have the face-to-face teaching. So then you'll have all the 4 face-to-face teaching in Syria lah. So but it's not ideal, it's not good, but at least we will have some idea when we can actually do proper teaching, proper medical teaching. At least we have, instead of macam okay masuk tak masuk ni buat ni tak tu semua tak tahu, semua tak sure, at least we have some dates that we can actually work on. So at least now we know, at least now you can know already that the plan is for you to have this online teaching until you finish all the 4 blocks. I'm not sure. I think there will be exams in between, probably 2 blocks kali exam ke, teori je. I don't know how. I know it's bad, but bertabah lah ya. At least you guys still have something. You guys, some people have to, many people lose their job and so on and so forth. And then, so at least you have this date how you can work on. So we'll do the online teaching, and then we'll have intensive face-to-face teaching when you guys come back here. But that will be like one posting after another with some element of clinical exam as well. So that is the plan. Okay, all right, Achi. So what are we going to do today? So um, initially I thought of doing something in the line of discussion about how to approach certain problems. But okay, I think how I would go about with this session is let's discuss some basic theories, which I always like to discuss with students, because I think if you understand the theory, if you understand the basic behind things, it will help you in terms of understanding what is the presentation involved, what are the physical examination that you need to get. Okay, first, when you clerk patient, when you try and get history from patient, when you try to examine the patient, and then you present the patient, what are the objectives of doing all those things? What are the objectives of clerking patient and presenting patient? What are the objectives? Anyone have any idea? This is something that I have always said, I have always repeated. If you look at the YouTubes of pediatric department, I will always mention this, because I think it's very important. Anyone has any idea what are the objectives of clerking and what are the objectives of case presentation? This is the basis of why we do exams for you all as well.
Doctor, is it about to know why the patient come to us?
So the first objective is actually to get to your provisional diagnosis. That's the first objective. when you clerk patient, when you examine patient, when you present the case to your senior, to whoever, to your lecturer, to your examiner, the first objective is to get to your provisional diagnosis, to sell your provisional diagnosis, to focus, to zoom in, to get your provisional diagnosis, because we will manage the case. We will do management based on what is our provisional diagnosis. We will initiate treatment. We will plan for the observation, monitoring, and so on and so forth. Will depend on what is the provisional diagnosis. So that is the first objective. So when you clerk the case, you should get enough history for you to tell us what is your provisional diagnosis, all the positive, all the information factors involving that provisional diagnosis. So for example, if your provisional diagnosis is asthma, for example, so your history, you need to assess whether the patient comes in acute exacerbation or not. If acute exacerbation, you need to assess the severity of the acute exacerbation, mild, moderate, severe, life-threatening, from history. You need to get to, not just that, you need to assess the status of the asthma. Is it newly diagnosed asthma? Newly diagnosed asthma also we classify according to intermittent or persistent. Persistent, mild, moderate, severe, persistent. If it's already underlying asthma, already on controller inhaler, for example, controller medication, you need to assess the control of the asthma with underlying control, partly control, poorly controlled asthma. So your history should get enough information to settle that. Eh? And your physical examination as well need to get enough information for you to make a proper provisional diagnosis. So both elements can ada. So that is the first objective. What is the second objective? What is the second objective? The second objective is to rule out differential diagnosis. To rule out differential diagnosis, and I expect from year 3 you should have at least 5 differential diagnoses. Year 5 I expect at least 7 differential diagnoses, meaning I expect from history you need to go through 5 other differential diagnoses. So one provisional and at least 5 differential diagnoses for that particular problem. So what are the points for that those differential diagnoses, and what are points against those differential diagnoses? So you need to get through, you put information on your HOPI, you need to put information on past medical history, you need to put those information on the systemic review and so on and so forth. You and your physical examination as well need to rule out at least 5 differential diagnosis. Faham tak? Sebabnya contoh asma, if you have a child coming, your provisional is asthma. What are other differential diagnoses of asthma? Pneumonia, bronchiectasis, other asthma phenotypes, episodic wheeze, multi-trigger wheeze, kan? So you need to think of all the other differential diagnoses, and I need you to have at least 5 differential diagnosis which you need to cover in your history and you need to cover in your physical examination, because as doctors you always need to think about what are the differential diagnosis. Okay, clear. What is the third objective? There's 4 objectives.
Rule out complication, to know if there is complication.
The third objective is to look for complications of the disease, because all disease, all problems has its own complication. If the child with asthma, for example, kan, dia ada complication dia, kan? CO2 retention, hypercarbia ada complication dia, kan? Pneumonia ada complication dia, and nephrotic syndrome ada complication dia, AGN ada complication. All disease has its own complication. So in your history, in your physical examination, you need to look for what are the complications that can happen and what are the complications that has happened. So you need to go through all those in your history and physical examination. What is the fourth objective then?
Management.
The fourth objective is actually to look for complications of treatment, because treatment may have been initiated. For example, if you clot a child, kejap. So if you clot a child, for example, if you clot a child at day 4, so if you clot a child day 4 of illness, maknanya before being admitted already have 4 days of the child being unwell. Do you think the mother may not have sought other treatment in other clinic, for example? So mother may have been pergi GP, pergi klinik tu, pergi klinik ni, and those clinics, those GPs may have started some treatment, and those treatment may have complication. The mother may have brought the child to traditional healer, for example, and those traditional healer may have started some mode of treatment, and those treatment have its own complication. The mother may even bought drugs by over the counter. Mak dia beli PCM, mak dia beli Piriton, mother buy antibiotic which they shouldn't do. Kan, mother may start some treatment, and those treatment may have some complication. So you need to look for those complication. If you clerk the patient at day 4, day 5 of admission, for example, kan, at ED, some treatment has been started. Kan, kat ED dia buat apa? Dia bagi nap, dia bagi ni apa semua, and all those have its own complication. So you need to look for all those complications. The child admitted for 5 days. Many things has been done in the ward for the past 5 days. So do they have complication? Yes, they do. Everything in this world has its own complication. Nothing in this world tak ada complication. Nothing. Everything ada complication. Not doing anything pun ada complication. So if people decided to not do anything, that action of not doing anything has its own complication. So what are those complications? So you as doctor, you need to look for those complications. What are the complications of nebulization, for example? What are the complications of steroid if you give steroid? What are the complications of antibiotics? Certain antibiotic can cause diarrhea, for example. Certain antibiotic can cause Redman syndrome. Certain antibiotic can cause Steven Johnson syndrome, for example. So certain drugs can cause liver failure. Certain drugs are nephrotoxic, toxic to the kidney. Certain drugs are ototoxic, toxic for your hearing. So what are the complications? Certain drugs, for example, salbutamol, can cause hypokalemia, low potassium. So what are the complications of low potassium? How will the child be presenting? So from your history, from your physical examination, you need to look for those complications. So these are the 4 objectives of clerking. These are the 4 objectives of case presentation. So what are those objectives again? Number 1,
to get provisional diagnosis,
to get to your provisional diagnosis. Number 2,
to rule out differential
to
diagnosis,
rule out differential diagnosis. And I need at least how much? At least minimum.
5,
Minimum 5 differential. So provisional 1, differential 5. So 6 at least. At least. Okay. What's the third objective?
Look for complication.
Nurain?
Complication.
To look for complications of the disease. Number 4.
Complication of treatment.
To look for complications of treatment, because everything has its own complications. So those are the objectives of when you clerk patient, you need to look for all these things. Boleh? Faham? So bila ditanya from one chief complaint, you can expand kan. What are the possible? So contohnya, okay, if a mother brought a child presenting with fever and seizure, what would be your provisional diagnosis?
febrile seizure,
So okay, febrile seizure, tapi febrile seizure nanti bila you present tak cukup febrile seizure je. So remember provisional diagnosis, you kena go detail about provisional diagnosis tu, you kena apa? You kena tengok dia simple febrile seizure ke, complex febrile seizure, history, family history, and so on so forth. So ada banyak benda yang nak kena tengok. So what are your differential diagnosis?
Epilepsy.
Meningitis dulu lah. Fever, seizure, always think number one should always be meningitis. Meningitis, encephalitis, epilepsy, and so think. So PK at least five differential diagnosis. Okay. Kesiannya si Shasha ni. Keluar masuk. Nampak dah 2 device dia try tadi. Itulah, this is the problem with home-based learning. What can we do? Can you imagine budak-budak sekolah rendah macam mana? Darjah 1 semua kalau di online teaching, 1 year dah tak belajar apa-apa. This year at least they can go to school. But I don't know how people in PKP areas are going to do. Okay, alright, fine. So this is the first thing that I want to discuss with you. Okay, that's the first thing. Okay, second. Okay, if a child presenting with facial puffiness, what would be your differential?
Nephrotic syndrome.
So nephrotic syndrome lagi? What are the differential?
Acute glomerulonephritis.
So AGN lagi?
Heart failure.
So cardiac failure, yes, congestive cardiac failure. Okay, alright. Lagi?
Chronic
SLE.
disease.
SLE, okay, SLE with nephritis lah. Okay, lagi?
Chronic liver disease.
So liver, so CLD, chronic liver disease. Lagi?
Chronic kidney failure.
Okay, CKD, okay, fine. Lagi? So you think systematic lah. Think systematic. Is there any infective cause? Any immunological cause? Anaphylaxis, kan, allergic reaction, infection. What infection can cause periorbital puffiness? Could it be periorbital cellulitis, for example? Preseptal cellulitis. Could it be traumatic? Could it be cardiovascular? So cardiovascular apa? Cardiovascular could be heart failure. Can it be something in the line of rheumatic? So cardiovascular. Could it be in the line of lung? What lung causes? If there is any. Kalau tak ada lah. Kan? What renal cause? Liver, GI. So go in terms of that system. Okay. Alright. Nephrotic syndrome. Okay. What is nephrotic syndrome? What is nephrotic syndrome?
It's a renal disease where there's increased permeability across the glomerular filtration.
Okay. Okay, do you mind telling us the pathophysiology of nephrotic syndrome? Anyone can tell us the pathophysiology of nephrotic syndrome?
So there's basically structural damage to the glomerular barrier. So that, so for example, the podocytes, the basement membrane, that allows the passage of more larger molecules such as protein, and that's how it causes the proteinuria.
Okay, lain. Anyone else?
it can also be caused indirectly by there's a scarring or deposition of the amyloid like exogenous material into the glomerulus.
Okay, so fine. Let's go one by one. So what's okay, so nephrotic syndrome, dia ada kriteria dia. What are those criteria? First is
Proteinuria.
generalized edema, anasarca. Second, proteinuria. Okay, so what is the level of the protein? What is the cutoff point? More than berapa?
40 milligram.
40 milligram per meter square? Or 1 gram per meter square per day? Kan 40 milligram per meter square per hour or more than 1 gram per meter square per day, or urine PCI more than early morning urine protein creatinine index of more than
200.
200. Okay, so that's urine protein. Okay, that's proteinuria. Next, so generalized edema, proteinuria, lepas tu
Hypoalbuminemia.
hypoalbuminemia. Value dia,
Serum albumin lower than 25.
so less than 25 gram per deciliter. Okay, alright. Lagi? Lagi apa lagi?
Hypercholesterolemia.
So, kenapa jadi hypercholesterolemia?
Due to dyslipidemia.
Dyslipidemia? Why? Kenapa jadi hyper?
Is it because of increased hepatic synthesis of lipoprotein due to loss of albumin?
So because it's just basically the liver trying to respond to loss of albumin, so they try to produce more of everything. Okay, all right. So what's the pathophysiology? First, there is changes in the GBM, glomerular basement membrane. So you know your okay, let me show something. So if you go here, so if you see blood vessel, it will go, this is the arteriole, goes into the glomerulus. This is the afferent, this is the so silap. Okay. So afferent and efferent arteriole goes into your glomerulus. This is your Bowman's capsule. Bowman's capsule, and then it goes into your proximal convoluting tubule. Then it goes into your loop of Henle, and then distal convoluting tubule, and then into the collecting duct. This is the collecting. This is my ugly drawing lah. I don't care. So this is your glomerulus. There's a glomerular basement membrane. Here you have the podocyte. So if you have the glomerular basement membrane, kan, dia punya cell dia, and in between this dia ada podocyte. Podocyte with this food processor. This podocyte dia ada food processors. Food processors. Podo tu maknanya dah. Podo means food lah, kan? So podocyte dia ada podocyte and its food processors. So what happens in nephrotic syndrome is that there are dua elemen. So how the podocyte and the GBM ni filters out is satu between the ni dia ada space between the cell. Yang kedua, podocyte food processors ni dia maintain dia punya size dia dan dia negatively charged. Sebab albumin is negatively charged as well. So dia prevent from things like albumin from going out. So what happens is in nephrotic syndrome there's inflammation. Dia affect dia punya glomerular basement membrane and specifically the podocyte and food processors. So apa jadi? The podocyte starts to efface. There's effacement of the podocyte food processors. Effacement maknanya dia makin besar. So the spaces become bigger. Sebelum ni kecil, dia jadi lagi besar. So lubang ni jadi lagi besar. One thing. And then the podocyte food processors also loses its negative ion. So dia start to lose dia punya negative dia. So bila dia become less negative, particles yang negatively charged boleh cross, boleh go across it. Bila dia lose its own negative charge. So what happens? Dulu albumin is a big particle, kan? Sekarang ni albumin can pass through the glomerular the glomerulus and gets into the Bowman's capsule and then goes into your until the collecting ducts and be excreted by the in the urine. So you'll have massive proteinuria. What is the result of massive proteinuria? So massive proteinuria results in hypoalbuminemia. Kan? Hypoalbuminemia. So what happens when there is hypoalbuminemia?
Low oncotic pressure in the vascular.
Okay, so it affects your Starling forces. You remember your Starling forces kan? Starling forces dia ada plasma oncotic pressure, plasma hydrostatic pressure, and then the interstitium, extravascular oncotic pressure and hydrostatic pressure. So reduce in hypoalbuminemia results in it affects your Starling forces, reduces the plasma oncotic pressure, relatively increases your hydrostatic pressure. So what happens? There is a shift of fluid from your intravascular space into your extravascular space, resulting in a third space loss of fluid. So fluid daripada intravascular goes into extravascular. Sebab apa? Sebab equilibrium dia dah lari, Starling forces dah affected, kan? Reduce plasma oncotic pressure, increase hydrostatic pressure, so fluid akan shift. So sebab tu fluid pergi dekat interstitium, jadi edema. Fluid pergi dekat peritoneum, jadi ascites. Pergi dekat pleural space, jadi pleural effusion. So dia jadi macam tu. So this is why, because of affection of the Starling forces. Okay, so and then what's going to happen bila fluid shift? What's going to happen? Fluid shift jadi semua simptom dia lah, edema, apa semua benda. And not just that, what it causes as well is that what's going to happen to your intravascular volume. Bila fluid shift from intravascular to extravascular, what's going to happen to your intravascular volume?
Depleted.
So your intravascular volume akan depleted. So this is what we call as underfill theory. So dia ada dua teori for nephrotic syndrome. Dia ada dua teori. Satu teori is underfill theory. So this is the underfill theory, the classical theory, where there is fluid underfill, where intravascular fluid is shifted to the extravascular space. So you will be underfill. So bila underfill, so blood pressure, heart rate akan naik, dan BP pun akan affected, and so on so forth. So this is the underfill theory. So bila you understand the pathophysio ni, baru you tahu apa questions you nak tanya, baru you can understand what investigation you want to send, baru you boleh understand what are the modalities of treatment. Okay, so this is underfill theory. So the other theory is the overfill theory. So the overfill theory is that there is also activation of the RAAS, renin-angiotensin-aldosterone system. Your ADH will be activated of your ADH, aldosterone system. So semua ni, and also vasopressin activation as well. And all this results in a overfill condition, where the amount of fluid shift from intravascular to intravascular, it is there, but it doesn't the amount of fluid that is fluid retention, because RAAS activation causes salt and water retention, kan? So there is oliguria. So the amount of fluid that is fluid retention is more than the fluid that is shifted to the extravascular space. So this, and also vasopressin. Vasopressin causes vasoconstriction. And all this results in a overfill condition. So masa ni you dapat hypertension, some oliguria as well. So the treatment will, you boleh tengok apa treatment dia. So kalau dia underfill theory, what can you do? What can you do in terms of treatment? So how do you treat nephrotic syndrome? So first is steroid, kan? If you look at the pediatric protocol. So again, I always remind students, if you want to read anything in pediatrics, for Malaysian student, your baseline reading should be Malaysia pediatric protocol for Malaysian hospital, 4th edition sekarang. Yang color purple tu, that should be your baseline reading. Basic reading you baca yang tu. Atas sikit pada tu you boleh baca yang buku Sunflower tu, Tom Lissauer, it's okay. Siapa nak baca apa nama Nelson, that's better lah. But at least you need to read the PIDS protocol. So if you read PIDS protocol, they mention that treatment for nephrotic syndrome kan ada prednisolone. Why? Because there's inflammation. So inflammatory process is the one that causes the problems in your podocyte and the food processes. The problem in your GBM is because of the inflammatory processes. So that's why you give prednisolone. And prednisolone dia ada dose dia lain-lain, ada induction cost, ada maintenance punya cost. Kan? So different doses for prednisolone. And prednisolone has its own complication. So you need to know pula what are the complications of steroid. Cushing, basically I'm talking about Cushing. Kan? So think, what are the complications of steroid? Because we see so many patients with nephrotic syndrome on long-term steroid and having all those complications. So look at all those complications. Okay, alright. Apa lagi treatment kita boleh bagi? Should you consider giving albumin? Yes, we do. We can give albumin if it's very, very low. So, do you want to give furosemide tak? You bagi albumin, kan? You nak bagi furosemide tak dengan albumin tu? So think, if the patient is underfill, then obviously you don't need to give, kan? So patient already volume depleted, already underfill, already volume depleted, kan? Kalau you bagi fluid lagi, you bagi furosemide lagi, kan? Dia akan hilang lah more fluid, dia akan jadi lagi hypovolemic lah, despite the edematous. Sebab edema does not equal to overfill. Edema is just that extravascular fluid tu banyak. It does not mean intravascular volume is okay. So the classical theory, the underfill theory is that dia ada intravascular volume depletion. Tak banyak volume dalam ni. So bila you bagi albumin, kalau you bagi furosemide pula, akan jadi hypovolemic lagi lah patient tu. Faham? Tapi kalau patient ni is overfill. Why overfill? Because of activation of RAAS, activation of vasopressin, ADH. So in this sense, you bagi albumin, then you need to give furosemide. Apa akan jadi kalau you tak bagi furosemide? Apa akan jadi?
Okay, makin teruk dia punya tu, hypertension ke apa.
Yes, you will cause more problem. Why? Sebab dia dah already overfill. And then you bagi albumin, fluid daripada extravascular masuk dalam intravascular. Lepas tu dia akan jadi memang dah sedia overfill. So the patient will be more overfill, more problem, more hypertension. Kan? More fluid overload. So So this is why you need to understand the pathophysiology of the disease, because if you understand the pathophysiology of the disease, then you can know how to treat. You know what are the history you need to assess, what are the physical examination you need to do for you to look at this patient belongs to which pathophysiology punya pathway. Okay, how about AGN? What is the pathophysiology of AGN? Siapa tak pernah cakap lagi? Aisyah Humaira ni. Tak dengar lagi suara. Kena dengar dah tadi? Tak perasan?
AGN antibody attack for the glomerulus.
Okay, lepas tu cerita lah sikit. Cerita sikit.
So it is because of the deposition of the immune complex. Usually it happen if the causes is the post-streptococcal, so patient maybe have a history of pharyngitis or skin infection.
Okay. So
So-
basic, cepat. Sambung.
Okay, so after 2 weeks, in 2 weeks time, so the immune deposition may attack the antigen, the basal membrane antigen.
Okay. Okay. So basically in AGN, you need to remember first, dia ada banyak causes of AGN. So wait, nephrotic syndrome ada multiple causes, ada banyak cause of nephrotic syndrome. Nephrotic syndrome we divide into primary and secondary nephrotic syndrome. So primary nephrotic syndrome dia ada minimal change disease. And kita discuss tadi mainly is about minimal change. Minimal change account to 80 to 90% of nephrotic syndrome. Dan dia ada focal segmental glomerulosclerosis, dia ada membranoproliferative nephrotic syndrome. Kan, itu yang primary. Yang secondary nephrotic syndrome dia can cause by so many things lah. SLE, lupus nephritis, connective tissue diseases, apa nama tu, Allah, HIV, hepatitis B, certain drugs, certain medication, henoxyline purpura can cause nephrotic syndrome as well. Okay, so sama juga dengan AGN. So AGN also ada many causes as well. Nephritis can be caused by so many reasons as well. But mostly is because of post-streptococcal glomerulonephritis, post-strep AGN. So what is the special thing about streptococcus ni? So it is a result following infection by group A beta hemolytic streptococcus, such as Streptococcus pyogenes, for example. Group A beta hemolytic streptococcus. So dia ada infection, usually by apa? Throat infection, pharyngitis, or skin infection, macam impetigo, for example. So there is this infection, and you know group A beta hemolytic streptococcus ni, dia ada capability for molecular mimicry, where it mimics the antigen of certain part of the body. Okay, so dia ada molecular mimicry, dan dia ada basically ada two yang well known punya strain yang cause problem to us. Dia ada cardiogenic strain yang akan cause in rheumatic carditis, rheumatic fever, kan? Dia ada yang nephrogenic strain. So this nephrogenic strain ni yang cause glomerulonephritis. So when there is infection, our body produces antibody to fight that infection. So, and when other antibody production, antibody will bind to the antigen and tries to kill it. It forms a antibody complex. So because of molecular mimicry, this antibody complex will then be deposited dekat your GBM. So antibody complex deposition on your glomerular basement membrane. So what it causes inflammatory processes, inflammatory reaction. There's so many inflammatory reaction occurs dekat your glomerulus, occurs at your tubules. So all these inflammatory processes yang menyebabkan your C3, C4 semua akan jadi affected. Complement activation, cytokine activation. So this will affect apa? Bila dia banyak sangat inflammatory process, it affects your glomerular filtration rate. So as compared nephrotic syndrome, dia tak ada effect GFR. GFR still normal. Tapi in AGN, your GFR is affected. So what happens bila GFR affected? Bila your GFR is impaired, there will be oliguria, reduce urine output. Kenapa reduce urine output? Sebab GFR dia affected. There is renal failure. So you can see your urea naik, your creatinine pun naik. Because why? Because renal failure. Why renal failure? Because inflammatory reaction happens at your glomerulus. Because filtration occurs at your glomerulus. So GFR is affected. Sebab itu in nephrotic syndrome, you don't need to fluid restrict. Sebab apa tak payah fluid restrict? Sebab dah lah dia underfill mainly kan. Dan GFR is not affected. You bagi banyak fluid keluar. Tapi in AGN, GFR is affected. There is renal failure. Sebab tu you kena restrict fluid nanti. Okay. So first, so yang deposit dekat the glomerulus is not the organism. It's not the organism that attacks your kidney. Streptococcus tu ignore pun kidney you. It's just your own body. The body punya antibody tu produce antibody complex, and this antibody complex deposited on your glomerulus and producing all the inflammatory reactions, cytokine activation and so on and so forth. Okay, so the effect GFR. GFR causes reduced GFR causes oliguria. So oliguria causes overfill, fluid overload, sodium and salt and water retention. Kan? Salt and water retention. So what happens bila you have fluid overload? You have edema, and you nampak periorbital puffiness, hypertension, so oliguria, and then hematuria because of inflammatory reaction, kan? So there will be hematuria, so oliguria, hematuria, hypertension because of fluid overload, and then renal failure, urea increase and creatinine pun increase. So when you understand this, what's going to be your treatment? How would you manage? Dia ada inflammatory reaction, kan? Already done damage your kidney. Okay. Lepas tu dia ada hypertension, dia ada fluid overload, dia ada hematuria. So what's going to be your treatment? So first is bed rest lah. Sebab you know bila you active, BP pun boleh naik. So bed rest. Kan? Kita cakap patient bed rest. Satu. Yang kedua, fluid restriction. Sebab dia punya main pathology is oliguria. Reduce GFR. Kan? Oliguria, reduce GFR, hypertension. So you fluid restrict. So how much fluid do you restrict? Kita restrict fluid, how much? 400 ml per meter squared per day. 400 ml per meter squared per day. Plus yesterday's urine output. So apa value 400 ml per meter squared per day ni? So 400 ml per meter squared per day is the insensible loss. The amount of fluid that you will lose this fluid, sama ada by talking, through your respiratory tract, through your bowel, through your sweat, and all this accounts to around 400 ml per meter squared per day. So you restrict fluid that much, 400 ml per meter squared per day plus yesterday's urine output. So you restrict fluid. Lagi apa lagi yang you boleh buat? So daily urine for inspection. Kita nak tengok ada gross hematuria lagi tak? Because gross hematuria, you can only allow discharge bila tak ada dah gross hematuria. But this sort of patient, dia boleh ada microscopic hematuria. And those microscopic hematuria ni boleh persist lama, boleh persist sampai 1 year, 2 years. That's okay. As long as tak ada gross hematuria. Kan? Okay. So you inspect the urine daily. Apa lagi? Hypertension ni, you nak buat apa? Apa you boleh buat for hypertension?
Give diuretics.
Yes, you can consider giving diuretics. What type of diuretics?
Loop diuretic.
Okay, what type of, name me one example of loop diuretic.
Furosemide.
So furosemide is a very good example of a loop diuretic. So you can give diuretics. You can give diuretics satu. Apa lagi yang you boleh bagi? You boleh bagi antihypertensive. What are examples of antihypertensive? You can give calcium channel blocker. For example, nifedipine or amlodipine. Mainly untuk children kita bagi nifedipine lah. Kan, nifedipine. Apa lagi? Calcium channel blocker satu. What else?
ACE inhibitor,
You can give ACE inhibitor. Name me one example of ACE inhibitor.
captopril,
So captopril, yes, captopril is a short acting, kan? Short acting punya drug. So you can give captopril. Apa lagi you boleh bagi?
enalapril,
Okay, itu different types of ACE inhibitor lah. Okay, so calcium channel block, apa diuretics, calcium channel blocker, ACE inhibitor lagi. Apa lagi boleh bagi? Shamimi, one example. What else you can give? Antihypertensive. Mana Syamimi? Syamimi satu example, lepas tu Siti Aisyah satu example, lepas tu Nurul Ain satu example. Right, we'll be waiting for you.
Enalapril.
Okay, itu ACE inhibitor. So tadi kita dah cakap, satu diuretics, yang kedua calcium channel blocker, lepas tu ACE inhibitor. Lagi apa lagi?
Beta blocker.
Okay, example of beta blocker.
Propanolol.
Okay, tapi propanolol biasa kita bagi pada untuk benda lain lah. Propanolol ni biasanya kita bagi untuk tetralogy of Fallot. Propanolol ni, so beta blocker causes smooth muscle dilatation. Smooth muscle dilatation. So usually kita guna benda macam labetalol or metoprolol macam tu. Okay, alright. So dololol ni geng-geng beta blocker. Okay, what else? Apa lagi? Aisyah?
Angiotensin receptor blocker.
ARBs, yes, we can give ARBs, angiotensin receptor blocker. Give me one example.
Losartan.
Losartan, setan ni semua geng ARBs, kan? Okay, alright. Lagi apa lagi? Nurul Ain, one more. So tadi dah ada beta blocker. So what else you can block?
CCBs.
Huh?
CCBs.
Calcium channel kita dah cakap tadi. So calcium channel, beta, apa lagi?
Alpha blocker.
Alpha blocker, yes, alpha blocker. Name me one example of alpha blocker.
Prazosin.
Prazosin, yes, very good example. So prazosin is a very good example of alpha blocker. So you can use all those drugs, all those drugs. Diuretics semua tadi kita tengok loop saja, ada banyak lagi jenis lain, potassium sparing apa semua. So these are all the drugs that you can give. Kan? So if you understand the pathophysiology, you know how to treat. Okay, alright. So why I always emphasize this? I always emphasize it because I think if you understand the pathophysiology, you know what questions to ask. You know what physical examinations to do. You know what investigations to send. You know what management to do. If you understand the pathophysiology. Sama juga dengan asma. If you understand the pathophysiology of asthma, so you kan tahu kenapa kita nak kena bagi mast cell stabilizer, kenapa kita nak kena bagi leukotriene inhibitor, kenapa kita nak kena bagi steroid, kenapa kita nak kena bagi beta agonist. So if you understand the pathophysiology behind the disease, you can understand why you initiate certain types of treatment modalities. Okay, alright, it's already 50 minutes. I think cukup lah untuk hari ni. Do I have other sessions with you? Tak ada. So I'm a very busy person, tapi tak apa. I don't mind. We can arrange another session ke? We can do some other discussion as well. If you want lah, tak apa. I don't mind. It's okay je. If you want, we can arrange another session because I don't believe in teaching longer than 1 hour. Ni walaupun tak sampai 1 hour, tapi I think it's already a bit banyak lah. Nanti kan ajar banyak bukan ingat pun semua kan, tak diguna kan. So might as well I give you some time for you to process, because if I were to make the question, I will ask about pathophysiology. Okay, if you have me for clinical exam, I will ask you about pathophysiology. If you have me for exam and the case is nephrotic syndrome, you will expect me to ask you what are the pathophysiology of nephrotic syndrome. You definitely should expect me to ask you the definition of remission, the definition of relapse, definition of frequent relapser, definition of steroid dependent, definition of steroid sensitive, definition of steroid resistant nephrotic syndrome. So those are things which I won't spoon feed you. I'm just telling you that if you get nephrotic syndrome, expect us to ask those questions. Kan? I think kalau examiner didn't ask you that question kan, macam dosa juga kot. Sepatutnya kena tanya ni. Definition very very important punya ni. Kan? So kena tanya. Tak adalah, I'm not saying that. I'm not bagi, kita tak tahu, Tuhan ni kuasa. Tapi maknanya these are things that you can expect. If you get me for examiner, you nampak ada budak tu kembung semacam edema dia, you know already what are the questions that I'm gonna ask. And so you remember, I'll ask you about pathophysio, I'll ask you about the definitions. Okay, alright. So because I do believe this is important, and you have so many nephrotic syndrome patients, especially as your exam will be Mann-Oski punya type ataupun modified long case. So in this case, memang obviously patients yang kita panggil daripada rumah. So bila patient yang kita panggil daripada rumah, there are certain criteria of the patient. It need to be stable patient, usually chronic diseases, not infective punya causes. Takkanlah kita nak panggil patient COVID bawa masuk exam kan? Kita kena ambil patient yang not infective lah. Nanti kan you dapat penyakit apa-apa, you saman UAE pula. Kan sekarang ni semua zaman saman menyaman kan? Bawa patient chickenpox, lepas tu student saman UAE sebab dapat dia chickenpox kan? It's not infective cause, so it's be stable chronic illnesses. So there are some certain criteria, and among the easiest set of patients to call are patients with nephrotic syndrome. Sebab dia ada, kita ada banyak dia, list dia ada banyak, they are easy to call, they can come anytime, and they have been coming to exams many times as well. Kan? So baca nephrotic syndrome, baca about AGN. Okay, alright. That's it. Any question?
Doctor, I have a question. So I've read before about nephrotic syndrome, and there's steroid sensitive and steroid dependence. Can the patient have both, or like what's the difference between the both, between sensitive and dependent?
Okay, what's the definition? What's the wording for the definition? Okay, cuba buka PITS protocol. What does PITS protocol say? Okay. Because the definition, you cannot have steroid sensitive while having steroid dependent. So a person that is dependent on steroid, maknanya dia sensitif to steroid lah. Dia steroid sensitif, tapi dia dependent. Yang tu dia boleh sama. Faham tak? Faham ke tak faham?
Doktor.
Tapi make sure you know how to define lah. What is the definition of steroid dependent? What is the definition of frequent relapse? What is the definition of steroid resistant? Okay, alright. Any other question? Okay, alright. I think that's it. Enjoy your time at home. Jangan makan banyak-banyak sangat Kejap lapar, PKP kan. Kejap lapar. Try to exercise as much as possible. Buatlah apa-apa benda yang patut. Use your time well to read. I know this is not ideal, but can you imagine one good thing about this pandemic is that it happens in 2020. If it happens in 1997, for example, when you only have the TMNet 1515 tu, trek kan. Nak buka satu page yang kosong pun it takes half an hour. So can you imagine if this happened at that time, kan, yang tak ada phone, kan. I got my first handphone masa masuk matrik. Yang tu pun memang berhutang apa semua nak beli handphone. Kan, satu handphone je, itu pun I was the first one in my group yang ada handphone. That was in the year 1999. So can you imagine at that time, game pun ada snake aja kan, dekat phone. Tak ada dah game lain. Sekarang ni macam-macam benda ada kan. So and at that time, kalau you nak buka journal, you kena cari semua physical journal. Sekarang ni you can look at journal by, you all have access to up to date. You all have access to Google Scholar. There's so many access to so many online resources. So at least it happens at this time when you have everything just by your fingertip. So make use of it lah. I know it's not ideal, but inna ma'al usri yusra. Kan, with whatever difficulty, there is some yusra, there is some ease, there is some good thing that's together with it. Allah doesn't mention following usri, there's yusra. Yusra does not necessarily come after the usra. Yusra comes together. Inna ma'al usri yusra. With difficulty, there is ease as well. With hardship, there is ease as well. So with whatever hardship that you are in, there is some bright in it. So look for those bright, enhance it, and make use of it. Okay, all right. Okay, let's end our session with tasbih kafarah in Surah Al-Asr. Okay, Assalamualaikum warahmatullahi.
Okay, Doktor.
Thank you, Doktor.
Thank you, Doctor.
Thank you, Doktor.
Thank you, Doctor.